Peace. Welcome. Peace, everyone. Hi, it's Heartland, and welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up in chapter 7. Welcome, YouTube. Peace, everyone. Hi, it's Heart Love. Welcome to the live YouTube book reading. This will be episode 23. Wow, getting up there. Peace, YouTube. Hi, it's Heart Love. Thank you for reading with us. Clinical Application of Respiratory Care. We pick up at page 147 today, August 27th. I wish you've all had a wonderful month and week. It's been riveting here as well. Today we have meditation with Lorianne Speed, and we also have a wonderful grocery giveaway here in South LA Cafe. So thank you so much for starting off forenoon portion of your day with us reading. Page 147 at the top, pulmonary oxygen toxicity. Although most of our concern in oxygen therapy is concentrated on preventing or reversing the hypoxemic state, the respiratory care practitioner must be knowledgeable and concerned about giving too much oxygen. This necessitates an unbiased and objective look at the subject, referred to as oxygen toxicity. As early as 1897, the importance of pulmonary dysfunction in the critically ill patient was recognized and emphasized. At the same time, it was debated whether or not the inherent toxicity of oxygen for tissues might limit its clinical applicability. We have previously stated that shortly after the discovery of oxygen, it was appreciated that there was a minimum concentration of oxygen that was compatible with life. Shortly thereafter came the appreciation that there must also be a maximum concentration compatible with normal cellular function. Investigators in the field of oxygen toxicity recognized this circumstance and unequivocally demonstrated oxygen toxicity nearly 80 years ago. It was not until about 1920 that oxygen was medically employed as a therapeutic regimen on any noticeable scale. In fact, it has been only over the last 3 decades that oxygen therapy has been widespread use. The major manifestation of oxygen toxicity has always been evident in the adult and were described as early as 1899. However, from the clinical viewpoint, there was little practical importance ever, Importance attached to oxygen toxicity until the advent of efficient mechanical ventilators that were capable of delivering continuous high oxygen concentrations and prolonging life in critically ill patients. It is well known that with chronic hypercarbic patients, the premature infants, severe clinical tragedies have resulted from the improper administration of oxygen. Nevertheless, the basic interest of attention of excess oxygen must be focused on the lung. And since it is this vital organ that is most often affected, most easily affected, and that has been most intensely studied. Peace. Welcome, YouTube. Thank you for reading with us and being at this peaceful place of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Neville Riley, highest heart love, and bottom of page 147, chapter 7, oxygen therapy. Here we go. Moving on. Pathology of pulmonary oxygen toxicity. Thank you for the likes and subs. We were pushing to 500 in this peaceful place of YouTube where we read books. So, highest heart love. Thank you. Just reading books, to the people. That's our playing our part, right? Highest heart love. Pathology of pulmonary oxygen toxicity. There are numerous factors that make the study of pulmonary oxygen toxicity difficult. Most information gathered about the pathology of pulmonary oxygen toxicity comes from animal studies. The identifications of changes attributable directly to oxygen and not to other factors is tenuous. The role of intermittent positive pressure ventilation in relation to pulmonary pathology and oxygen toxicity is debatable. It seems fair to conclude at our present state of knowledge that intermittent positive pressure ventilation does not play an important role in the advent of pulmonary oxygen toxicity, as long as the positive pressure applied is not excessive. However, IPPV may well play a significant role in the course of pulmonary oxygen toxicity. Peace, highest heart love, Tegan. Thank you for reading with us in this peaceful place of YouTube. Thank you for the likes and subs where we read books and learn. This peaceful corner of YouTube. We're reading clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're in chapter 7 here. There are two types of pulmonary changes that arise from excess oxygen. The chronic type of oxygen toxicity is found in response to low concentrations over many months. This is associated with proliferative changes in lung endothelium and epithelium. In contrast to this type of toxicity are the changes produced by exposure to high concentrations of oxygen over short periods of time, several days to weeks. This acute toxicity is usually divided into two places: an immediate exudative phase and a slightly delayed or proliferative phase. Our discussion will be limited completely to the syndrome of acute toxicity. Knowledge concerning the structural changes in the lung because of oxygen has been considerably advanced by one, the application of new techniques for quantifying lung damage, and two, the widespread application of electron microscopy. These methods have been utilized in both hyperbaric, above atmospheric pressure, and normobaric, atmospheric pressure conditions and have revealed interesting differences between rats and monkeys. One must question how this differences between rats, how this pertains to man. In general, the pathologic findings that have been found in acute pulmonary toxicity are consolidation, edema, alveolar cell hypertrophy, hyperplasia, degeneration, and desquamation. In addition, hyaline membranes have been reported surrounding or lining the alveolar cells and ducts. Recent studies show that the hyaline membranes seem more likely to be found in oxygen toxicity of long standing. The electron microscope has made possible the study of the ultrastructural sublight microscope changes in oxygen poisoned lungs. The overwhelming evidence is that prolonged exposure from 3 days to weeks to high concentrations of oxygen leads to abnormal changes within the mitochondria of alveolar type 2 cells. See chapter 1, which we already talked about. Thank you so much for being here reading with us. Highest heart, love, and honor. Much love. Peace. All the August babies and birthdays. Highest heart, love. We're down at the bottom of page 148 in chapter 7, Oxygen Therapy, here live on YouTube. It must be emphasized that many of these pathologic changes are nonspecific and may be seen in pneumonia, post-tradition lung, and post-cytotoxic anti-cancer drug administration. Not all studies have been limited to animals. There have been numerous attempts to study pathologic lungs finding in humans who receive high concentrations of oxygen for prolonged periods. Most of these studies are inconclusive because one, they are retrospective and therefore present obvious difficulties in interpretation. Two, many are dealing with hyperbaric conditions. And three, many involve circumstances where pulmonary disease was present prior to oxygen administration. At the present time, these studies are far too inconclusive to be used as a basis for clinical application of oxygen therapy. Thank you for the likes and subs. Peace, peace, YouTube. We're doing it. We're pushing towards 500, reading books to the people, providing a service here on YouTube for free. When you get $1,000 of work like this for free, it's always a good deal, right? That's how you do it. Thank you so much for the likes and subs. Page 149 at the top. Human tolerance to oxygen. The preceding review makes it obvious that most of our information concerning acute pulmonary oxygen toxicity is based upon animal studies and human hyperbaric studies. The respiratory care practitioner is concerned with the effects of oxygen in man at atmospheric pressure. Reports that occasionally occasional patients have survived exposures to oxygen much greater than was thought possible has led some to question whether oxygen toxicity actually exists in man at normal atmospheric pressures. However, it is fair to state that sufficient data exists to demonstrate unequivocally that acute pulmonary oxygen toxicity is a real entity in women and men. Ding! We know that, right? Connect the dots. In healthy man, there seems to be a threshold, 50 to 70% oxygen, below which there is little evidence of acute oxygen damage. It also seems apparent that despite wide variations in human susceptibility, sub, yeah, susceptibility, there is little identifiable risk in the administration of pure oxygen at 1 atmosphere for 24 hours to a healthy woman or man. It appears that the rate of the onset of the disease process, oxygen toxicity, is proportional both to the tension of oxygen and to the duration of exposure. Reasonable interpretation of data obtained from the manned space program indicates that no measurable changes in pulmonary function or gas exchange occur in man during exposures to less than 350 milliliters or millimeters Hg, zero point 0.5 atmosphere of oxygen. There seems to be little argument that it is primarily the pressure tension of oxygen, not the concentration of oxygen, which is the determinant of the development of toxicity. Obviously, adequate arterial oxygen tensions are the endpoint of oxygen therapy. Cellular toxicity due to blood hyperoxia should never occur. However, clinical situations arise that appear to demand high FiO2s. The danger of such therapy is that it will eventually lead to pulmonary disease that will threaten tissue oxygenation. There appear to be two mechanisms that play a major role in creating pulmonary abnormality purely as a result of high FiO2s. One, alveolar cell malfunction, pulmonary oxygen toxicity. And two, absorption atelectasis, the entity of acute pulmonary oxygen toxicity is a biochemical process of great complexity. Since lung parenchyma is exposed to higher oxygen tensions, alveolar PO2, than any other tissue, it is small. Wonder that under normal baric conditions, the lung is the first and most common organ to manifest oxygen damage. Mitochondrial dysfunction, dysauxia, is related to the inspired oxygen level and the duration with which the epithelial cells are exposed to high alveolar tensions. Alveolar epithelial cells, see chapter 1, are sensitive to hyperoxia. This is true for both types 1 and 2. Their dysfunction leads to a clinical entity known as adult respiratory distress syndrome. See chapter 30. Biochemical oxygen toxicity is not the same in normal baric and hyperbaric condition. Hyperbaric pressures seem to offer significant protection against central nervous system and pulmonary oxygen toxicity. However, there is no evidence to support the concept that the same protection exists in normal baric conditions. Available evidence indicates that the neuroendocrine system plays a much greater role in the response of the lung to hyperbaric oxygen than to normal baric oxygen. However, it is apparent that the neuroendocrine system plays a role in both situations. It has been suggested that the variation in individual susceptibility to acute pulmonary oxygen toxicity may be due to the variation in neuroendocrine activity. Peace, highest heart love. Thank you for reading medical books with us. I know that I have that vocabulary to do it, so you know. It's like, why not give them the best? This is giving them the best. I love you. Thank you so much. Middle of page 150. Thank you for the likes and subs. Highest heart love, Tegan. Peace, peace. Thank you for reading with us. Love to everyone. Canada. Highest heart love. Live from LA. All right, down at the bottom, page 150. Absorption atelectasis. Atelectasis. Nitrogen is an inert gas, i.e., it does not enter into chemical reactions within the body. It freely distributes throughout the total body water, and therefore the nitrogen tension, PN2, is equal in the alveolus blood and cellular water. Under normal conditions, approximately 75% of the alveolar gas is nitrogen. When 100% oxygen is administered, the entire body will denitrogenate, denitrogenate within 30 minutes. Ding! Wow, that's powerful. Within 30 minutes, it will denitrogenate. It is believed that this denitrogenation may result in some alveoli collapsing due to absence of gas volume. However, this process appears to be of great import in diseased lungs where poorly ventilated alveoli have low PO2 but adequate nitrogen gas volume. These hypoxic alveoli receive little blood flow because of the local hypoxic vasoconstriction. When the FiO2 is increased, the alveolar hypoxia is relieved, resulting in increased perfusion. This redistribution of pulmonary blood flow may be responsible for these areas of lung collapsing. Peace, highs, heart, love, Bartek. Thank you for reading with us. Highest honor. When this process occurs, shunt effect is replaced with true shunt, a refractory hypoxemia. This may lead to the situation where higher and higher FiO2 results in lower and lower arterial PO2. All right, we're page 151. Thank you so much for reading books with us. Highest heart, love, and honor. All right. Summary, page 151 at the top. We're doing it. The fact that high concentrations, greater than 50 to 60% of oxygen administered for long periods, 3 days to weeks, may cause acute pulmonary toxicity is well documented. However, it is essential to keep in mind the relative danger of hypoxia and hyperoxia. The pathophysiology of hypoxia in the critically ill patient has been aggressively treated for only 2 decades. In that time, numerous therapeutic manipulations, including oxygen therapy, have become normal practice. In the application of these treatment techniques, oxygen has often been abused, and there is little room for disagreement that oxygen toxicity is a real iatrogenic, doctor induced disease. However, an overreaction to the dangers associated with oxygen supplementation has led to an extremely hazardous circumstance, poorly informed clinicians withholding essential oxygen therapy from hypoxic or hyper hyperpoxemic patients. To allow a patient to be exposed to dangerous levels of hypoxia for fear of developing oxygen toxicity is intolerable. So that's a big no, no. Okay. So you can put that in red where you're taking notes, put a big check there, a big line and mark wherever you take notes of this, because obviously this is the summary part. You want to make a big note of that. I'll read it again. All right. Thank you so much for reading with us. Highest heart, love, and honor. Peace, peace. Highest heart, love. I'll read it again. To allow a patient to be exposed to dangerous levels of hypoxemic or the levels of hypoxia for fear of developing oxygen toxicity is intolerable. It is essential to remember that hypoxia is common and that the damage it causes is rapid and severe. On the other hand, pulmonary injury from oxygen is uncommon and its development is relatively slow. Careful consideration of all the evidence, along with sound clinical principles, leads us to make 3 generalizations concerning oxygen therapy and oxygen toxicity. Peace, stop and smile. Hi, it's our love. Welcome, August 27th. Thank you so much, Stop and Smile. Hi, it's our love. Good day to all, she says. Much love. We love you here. Much love. Thank you for the hearts. I see it fluttering and the likes. We're pushing to 500. Reading books. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Preparing the next generation for the MCAT. Thank you so much. All right. We're closing out on chapter 7. Yes, I know, right? Stop and smile. It's amazing. I hope all is well, she says. And oh, very nice. Thank you so much. Oh man, this is so beautiful. We just celebrated my solar return 2 days ago. So on Monday. Thank you so much for being here. Under normal baric conditions, there should be no hesitation in providing appropriate low concentration oxygen, less than 40% for supportive therapy of the cardiopulmonary system, even in conjunction with appropriately administered intermittent positive pressure ventilation. Low concentration oxygen rarely produces pulmonary toxicity. And two, pulmonary oxygen toxicity in man or woman has not been demonstrated from breathing 100% oxygen for 24 hours or less. Therefore, oxygen toxicity should not be a consideration intraoperatively in resuscitation or in transport situations. Pure oxygen has no contran- contraindication for brief periods in emergency situations. However, absorption atelectasis must be kept in mind as a potential problem since this can occur within 30 minutes. The lowest possible FiO2 should be administered as early as feasible in the clinical course. And three. Here we go. The three. This is number three. Page 152. Thank you for the likes and subs. Much appreciation. Patients with pre existing pulmonary disease are no more prone to develop acute pulmonary oxygen toxicity than patients with normal lungs. However, pre existing pulmonary disease is more susceptible to absorption atelectasis. Our clinical concern of acute pulmonary oxygen toxicity must not differ between the pre existing non disease and diseased lung. The general principle of minimal oxygen administration, consistent with adequate cardiopulmonary homeostasis, always holds true. High FiO2s are most commonly administered to patients with primary cardiopulmonary disease. Therefore, although the pre existing pulmonary disease patient has no inherent increased risk of acute pulmonary oxygen toxicity, he or she is the patient who will most likely receive high oxygen concentrations. All measures possible must be instituted to allow minimal FiO2s for maintenance of adequate oxygenation. Such measures include ventilatory patterns, fluid restriction, maintenance of electrolyte and acid base balance, and the institution of positive and expiratory pressure, PEP, where indicated were indicated. Of course, basic modalities of bronchial hygiene to improve distribution of ventilation and decrease work of breathing are essential. The avoidance of excessively high inspired oxygen concentrations is a common issue in critical care units. One must realize that appropriate tissue oxygenation is essential to the maintenance of life, especially in patients with multi organ system disease. There can be no dogmatic guidelines concerning appropriate degrees of arterial oxygenation to assure tissue oxygenation. This must always be a clinical decision based on thorough knowledge of cardiopulmonary homeostasis, careful monitoring, and physical examination. Arterial blood gas measurement is essential for the appropriate administration of oxygen therapy. We did it! Concluded chapter 7. Thank you so much. Thank you so much. We are moving on through section 3, bronchial hygiene therapy. When we reconvene with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading with us, being here with us on this beautiful Wednesday, Meditation Wednesday coming up. And then we have a beautiful grocery giveaway here, South LA Cafe. Thank you so much, live from the light here in LA, reading books. We're pushing towards 500. Thank you so much. Stop and smile. Chapter 7 is complete. That's right. Much love. Man, I have to make you a mod. Stop and smile. I really appreciate you. Let's see. Add as mod. Yes. Let's show that love. Much love. Hope you get that love. Nice, hard love. Thank you for reading with us. Oh, I always love seeing you live. Thank you. And I love seeing you too. It's that time of the day, right? Where we can really, really show love to one another and uplift one another, right? So, highest heart, love, and honor. Thank you for reading books with us. Some love water to walk us out into the day. Hope you look up and see something beautiful. See a butterfly flying at you or a bird just swoop down. You can tell it. You love it. I love you. Thank you. I love you. I love you. I love you. What a beautiful, beautiful day. Happy Wednesday. Love to all the August 27th babies, right? All our friends and families that we honor. I love you. I love you. I will see you soon. Highest heart love. Thank you so much. Peace.